Welcome, my name is Dr. Marto. I'm one of the rheumatology consultants, both at LIPS and I work from King's College Hospital as well. I'm just going to share my screen to start the presentation. Okay. So when I started thinking about what I was going to talk about, one of the things that was suggested to me was to maybe just talk about the top 5 things that I thought were most important in rheumatology. In hindsight, this may have been a bit too much, but I think what we should do is go through really the pearls and pitfalls of what I think are the most important things to think about. So as a starter, in the next 60 minutes, I'm planning on giving you just a revision and update of the top 5 most common systemic rheumatology presentations. And this is going to be new onset inflammatory arthritis, seronegative spondyloarthropathies, gout, giant cell arthritis, COVID-19 and the rheumatological manifestations. And then in terms of the pearls and pitfalls, it's the focus mainly on the questions and problems that I most commonly get asked in clinic. So day-to-day management of things that people ask you that aren't really in the textbooks. And then this is just a reminder that please use the Q&A just to ask any questions, and then hopefully I can come to them as we go along. So to start with, new onset inflammatory arthritis. So this is the bread and butter really of what we do in rheumatology. And the things that I'd quite like you to take away from this are the need and recognition for early referral. So why is it important to see these patients early and what benchmarks are we using to make sure that we do this? And then looking at key questions, tests and investigations that are going to help you make the diagnosis, treatment pathways. And then there's always a few grey cases, so pitfalls in recognising things that don't quite follow the pattern of what you think that you're going to find. And then I'll also talk about some imaging and the role of disease-modifying agents. So why? Why do we really care about why early arthritis is so important? So rheumatoid arthritis, and in particular inflammatory arthritis, we know are progressive, destructive and disabling, and actually are associated with increased mortality, mainly due to infection, respiratory and cardiovascular disease, which arise for 2 reasons really. 1 from the actual disease itself, and then 2 as a side effect of the medications that we use. It's important to remember that most destruction occurs in the first 2 years of disease, and this isn't always clinically apparent. And so the timing of presentation to secondary care in this case is vital. We know that early treatment and remission can result in good outcomes for most patients. And also there's cost implications. And following on from this then, in 2013, NICE introduced 7 quality care standards for adults with rheumatoid arthritis, which was then revised in 2020. And I'll come to that in our next slide. On this side of the slide, actually, if we can just focus, if you look at the treatment for rheumatoid arthritis in particular, we've come a really long way really in the last 2 decades. So in the late 1800s, we were starting to use aspirin. We got to gold and corticosteroids by the 50s. Methotrexate was a game changer. So that came in 1970. And then from 1999 onwards, really is where we've seen sort of almost a huge growth in biological agents. So our choices of conventional DMARDs now in terms of methotrexate, sulfasalazine, hydroxychloroquine and leflunomide. And we've got a huge range of choices of biological DMARDs now. And I've listed them here, and there's more on the horizon, but we have a choice of TNFs, IL-6 inhibition, JAK inhibitors, CTLA-4 blockade, which is abatacept, and then B-cell depletion through rituximab. And I think the thing that's really going to be a game changer at the moment is that NICE have recently, in the last month or so, approved therapy for moderate disease activity. So this is going to open up the world of biologics to a huge number of people who previously we had to wait until their DAS28 score was over 5.1 before we could treat them. So this slide is busy. And actually all I really want you to do is focus on the red. So in terms of the NICE quality care standards, and this is quality standard 33, if you'd like to look it up, when you see somebody with persistent synovitis or joint inflammation, they should be referred to secondary care within 3 working days of presentation. Quality standard 2 means that we should be seeing them within 6 weeks of referral. Educational activities that support self-management should be paramount, and they should be part of every patient's journey. And we are supposed to be able to attend to our patients within 1 working day. So most places will have a nurse helpline number or a nurse email, and we should be able to respond to them within 24 hours. And I think the last point is interesting, particularly for primary care, as this has been, I think, a topic of debate over some years, as to whose responsibility is it to carry out the annual review. And NICE make it quite clear that actually the comprehensive annual review should be coordinated by rheumatology. So how do we improve? Now, I don't expect you to read this slide or do anything with it, but it's just to show that actually there are lots and lots of different things to be aware of in trying to improve and increase the proportion of people referred by their GP within 3 working days by 5%. And I've just highlighted here actually what the role of the primary care physician is, but also not to forget that there's also physiotherapists, orthopedics, and dermatology that also see patients with inflammatory arthritis. And the things that I really actually want to highlight are, number one, that the GPs are aware of the National Inflammatory Arthritis Audit, which I will talk about. And I think the other really important thing on this slide is that GPs to refer immediately without waiting for test results. And I think that's a bit of a problematic statement, because I think we all know that when we're triaging referrals, it's nice to see that the blood tests and the x-rays are done. Most early arthritis clinics have pro formas, actually, where you have to put down what the blood tests were. So whilst that's been recommended, I appreciate that's a difficult thing sometimes to achieve. So how are we measuring what we're doing? So the National Early Inflammatory Arthritis Audit is run by the British Society of Rheumatology. It is pretty much all trusts in the country are signed up to it, and it collects data on how quickly patients have referred and when we're seeing them. And actually, at the moment, we're not doing particularly well. So this is data from 2019 to 2020. Now, bearing in mind this does include the pandemic, the figures are slightly lower than we would expect them to be. But I've picked out actually the key things that I think are important. So in the last 12 months, less than 50% of patients were referred within 3 working days of presentation to primary care. And also less than 50% of these patients were seen in secondary care within 3 weeks. So this is something that we really need to improve on. And the other thing that I thought was really interesting is that only 38% have access to psychology services. And I know this is something that particularly during the pandemic, both primary care and secondary care have found very difficult, because we just don't have the services to be able to offer everyone psychological support, despite it being recommended. And then finally, 77% of departments in the country offer an early arthritis clinic. I've used this slide just to highlight that actually pretty much across the country, things are the same. So there's not one particular area that's doing much, much better than others. The Welsh GPs seem to be good at referring, but actually if you look at the green, which is a delay in over 6 weeks to be seen by a secondary care physician, it's pretty equal across the country. So countrywide, we probably need to be doing a slightly better job. So having talked about the inflammatory arthritis and the importance of early recognition, I've used this slide just as a reminder, really. So you have someone that comes to see you and they say, my joints are painful and stiff. And the most common thing you'll probably see is gout. And I'm going to start in this corner here. So gout, depending on which study you look at, affects between 1 to 6.9% of the population. We know it's got a preponderance for men, acute swelling that's short-lived, often associated with a multitude of risk factors. I've put in uric acid here, but it's really important to remember that actually uric acid can be normal during an acute attack. So sometimes the uric acid crystals will precipitate into the joint. X-rays are pretty important in gout as well and often get overlooked, but actually if you've got first MTP erosions, that's a really good sign of when to start treating aggressively. An aspiration to get the gout crystals is pretty much gold standard. I'm going to pop over to this side. So rheumatoid arthritis is the other thing that you're likely to see. Most of what I see, but important to remember that it only does affect 1% of the population. Women more than men, characterized by early morning stiffness and swelling. And in terms of the bloods that we really need, the ESR and the CRP, and then the rheumatoid factor and CCP antibodies. The CCP antibodies actually to me are really the most important thing, because if you've got a low level rheumatoid factor, often CCP positivity is the thing that is really important, as it's more specific for the development of rheumatoid arthritis than just rheumatoid factor. X-rays of the hands, feet and chest are always good, and then I'll talk a little bit about ultrasound as well. In terms of psoriatic arthritis, so generally this is obvious if somebody has clear psoriasis, but again, I think it's really important to remember that psoriasis isn't always obvious. So places to look include the scalp, behind the backs of the ears, the navel. And then the other thing is that if there's not clear joint swelling, but they've got generalized pain, tendinopathy and dactylitis are sometimes the feature of some people's disease. So it's really important to ask about recurrent tennis elbow, to ask about recurrent Achilles tendonitis. A family history also is quite important. I'll come to that later on in the talk. And in terms of blood tests, so most people will get a rheumatoid factor just as part of their screening, and an HLA-B27 usually we will do in secondary care. And I think the other important thing to say is that often in psoriasis, the CRP can be normal. So it's difficult because some people will say, oh, well, where's the evidence? But I've seen many patients actually with quite extensive psoriatic arthritis, but a normal CRP. In terms of the other two, they're much less common. Ankylosing spondylitis is only around 2,000 cases a year in the UK. Men more likely than women. And the key thing with this is that often they present late, and hip involvement and uveitis tend to be worse markers of disease. So in terms of x-rays, usually I'm looking for the SI joints, and I will come to what to find on the MRI. And then I've just put in a small sort of box on other arthritides, which are much less common, but not to forget to ask about recent STDs or travel. Lyme disease sort of comes and goes as to being hot in the press. So, you know, Avril Lavigne had Lyme disease. And particularly in London as well, the other thing to often think about is sarcoidosis, which tends to present much more as periarticular swelling as opposed to articular swelling. Oops. So most of us, I think, are probably quite happy in terms of, you know, there's a swollen joint, when to refer, who to refer. Pitfalls that I could think about are, so erosive arthritis is a completely different clinical entity. Mainly affects the PIP joints and the DIP joints. And the way that it presents is a mix really between almost a crystal arthritis and osteoarthritis. So usually there'll be an abrupt onset of inflammation with pain and limitation in function. Depending on what studies you look at, it's quite common. So between 2.8 to 10% of the population. And if I draw your attention to the x-rays on this side, as you can see, you wouldn't be wrong for thinking that this was a erosive inflammatory arthritis. So you can see there's a distinct lack of joint space, and almost this looks like what we call it sort of a gull and wing erosion that you can sometimes find in psoriatic disease. And this can be quite painful and quite debilitating, and the age range can sometimes be quite young as well. So I've seen erosive osteoarthritis in patients as young as 40 or 50. So two things really, that this does still warrant a referral to secondary care. But the next question for me is, well, what works? So what do we do with patients that have got erosive osteoarthritis? And really on this table, I think the thing to look at is that all of this says no improvements. So there have been clinical trials that have looked at both anti-TNF and anti-IL-1 and other monoclonal antibodies in osteoarthritis, and there's been no effect in clinical pain scores or imaging outcomes. And I think the really important sort of game changer study really was hydroxychloroquine. So patients were randomized to receive hydroxychloroquine if they had a diagnosis of inflammatory arthritis, and this actually showed no efficacy. And so anecdotally, some patients find that hydroxychloroquine does work in inflammatory arthritis, but it's now quite hard to justify prescribing it, particularly in the light of that big study. So usually what I will do is treat this as osteoarthritis, but what I tend to say to patients is The guidelines say that nothing works, but anecdotally, I know that occasionally an intramuscular steroid will work or an intra-articular steroid will work. And for some people, hydroxychloroquine does work. And if I really feel clinically that this might be the case, then I make a contract with the patient. So we say we will try 3 months. If at 3 months there's absolutely no difference in your pain scores or limitation, then we stop it and we treat this just as osteoarthritis with the pain pathway. And often these patients with inflammatory osteoarthritis end up needing surgery or joint replacements or trapeziectomy because it is quite painful. The second pitfall is palindromic rheumatism. And again, this is a distinct clinical imaging phenotype where really what it tends to do is affect the periarticular tissue right at the beginning rather than the joint itself. And so what you'll find is, whereas these joints don't look like acute synovitis, there is a generalized swelling of the fingers. And there's a lot of debate. So whether it's the prodromal phase of rheumatoid arthritis, and this is usually the case if the antibodies are positive. So if there is CCP and rheumatoid factor positivity, then normally I will treat it as a prodrome of rheumatoid arthritis. The joints that are most commonly affected are the wrists, the MCPs and PIP joints. And the real problem with palindromic rheumatism is you can almost guarantee that by the time they come to either see the GP or myself, the joint swelling has completely gone. And so what I tend to say to patients is just take lots and lots of pictures. Most people have got smartphones now. And if I can see pictures of joint swelling and that comes and goes, and that really helps me make the diagnosis. And in terms of the amount of patients that will progress to a full-blown arthritis, so there's a Finnish palindromic cohort, and they looked at 60 patients, and 75% of those progressed to full-blown rheumatoid arthritis in the first 10 years. So what I'd say is please refer these patients in, get them to take lots and lots and lots of pictures. And ideally in secondary care, what we would love to provide is an SOS appointment. So if I can see the patient when they've got their joint swelling and I know that their inflammatory markers are raised, that really, really helps me to make the diagnosis. I'll move on to a few pearls that I tend to use. So on the right of this slide is your standard rheumatoid arthritis X-ray with erosions. And what I'd say is when we've got to that stage, we've probably missed the boat a little bit. It's too late. We shouldn't be letting people develop erosions, particularly with the early inflammatory arthritis pathway. Now, I appreciate that also depends on when the patient chooses to present. But what I've chosen to show you instead is actually early focused ultrasound is really quite helpful in making a diagnosis. So normal joints are usually only 1 cell thick. And as you get an inflammatory infiltrate, so the cells infiltrate the joint, what you'll find is the actual joint lining gets much thicker. And you can see that on grayscale in the ultrasound. So what you're looking at is, here's a normal joint. So you've got your joint line here, you've got your tendon over the top, and usually you'll have some cartilage right in the middle, which is normal, a triangle. And as the disease progresses, what you'll see is this dark grey lesion, the dark grey area tends to get thicker. And we grade this from 1 to 3. And as the disease progresses, you get increased thickness of the synovial lining, and you can see that quite nicely on ultrasound. And then as you've got new cells in the joint, actually all those cells need a blood supply. And so when we look at powered Doppler scores, what we see is that there's a new blood supply that comes into the joint to try and give these inflammatory cells some life. And again, this is scored from 0 to 3, depending on the intensity and the area of the color Doppler. And I think this is the most important thing. And for me, I'm happy that I'm able to incorporate ultrasound into my initial assessment. And often it gives you the diagnosis there and then on the day when it's not obvious. Conversely, it's also really helpful when there's not inflammatory arthritis and you think the diagnosis is much more likely to be fibromyalgia, because I think it really helps patients to be able to see their joints and to be able to see what their disease is. And then moving on a little bit, so the other thing that I often get asked on a kind of day-to-day basis is, what are we monitoring? And you know, I think from a secondary care perspective, we happily send shared care guidelines across to primary care. But I think it's really important just to know what we're doing and why we're doing it. And sometimes some blood tests are a little bit overkill. But standardly, so for methotrexate, sulfasalazine and enzalutamide, We ask for 2 weekly blood tests for 6 weeks and then monthly. And then once the patient's stable on the drug, I will let that drop to 3 monthly. The biologics actually need much less monitoring. So usually for TNF and JAK inhibitors, I will say between 3 and 6 months. And for IL-6 blockers, slightly more often because they're much more likely to have a drop in neutrophils or change in liver function tests. The next column, I've just said some extra tests that are specific to each drug. So hydroxychloroquine eye screening, guidelines have recently changed. So unless you're high risk, you don't need screening at baseline. But we do recommend screening once every 5 years, or if you've got risk factors, and that includes a reduced eGFR, diabetes, or pre-existing eye disease. Most people get a chest x-ray prior to treatment. Leflunomide is a special case in that it does require blood pressure monitoring. And this can be quite problematic actually for some patients and can make their blood pressure go up quite a lot. And then the other thing to point out is recurrent infusions of rituximab can cause IgG deficiency, which leaves you more prone to infections. And then JAK inhibitors can make lipids go up. So that is something extra that we measure. And then for the last column in this table, I've just put a little list of what's compatible with pregnancy and what isn't. So hydroxychloroquine and sulfasalazine, we will not stop. What I tend to say to people though, is to take some extra folic acid if they are on sulfasalazine. Methotrexate, we stop for a minimum of 3 months. And leflunomide, I try and stay away from prescribing in any woman of childbearing age, unless I absolutely have to. The reason for this is it's much more teratogenic than the rest, and you do need to do a cholestyramine washout. And often you're then left with this really difficult consultation of what you advise the pregnant lady to do with her pregnancy. In terms of biologics, there's been quite a lot of data now. We know that certolizumab pegol is safe in pregnancy, so we will continue that all the way through. Humira and some of the others we will continue, but if we do continue the others through, we try and stop them at the 3rd trimester. If we do continue them, we delay the baby's vaccinations by 8 weeks. And the others, although I've written not recommended, the truth is we haven't got data, so we don't know. And then finally, as part of my early inflammatory arthritis part of this talk, if you have to start steroids, and we all know this, so, you know, there's always this, oh, the GP started steroids, and sometimes you just have to. If you see somebody on a Friday afternoon and you know that there's not going to be any access to urgent rheumatology, what I tend to say to people is try and manage with non-steroidals until they can be seen. But if you really, really can't, then if we can do the bloods and the x-rays prior to steroids, that's really helpful. Again, I'm a little bit obsessed with pictures, but as many pictures of swollen joints before steroids as well. If we can try and use the lowest dose possible, so often for most people 15 milligrams is enough. And the other thing to be aware of is that actually steroids and psoriasis can cause a skin flare. So if there is somebody with quite extensive psoriasis, I would just be a bit cautious of giving oral steroids. And then if it is the first episode of suspected gout or pseudo gout, I think it's really, really helpful to get an aspirate when we've got fluid. And often if steroids are started, we miss that window. And then if the diagnosis later on is questioned, it just makes it difficult to do retrospectively. So that was a little bit of a whistle-stop sort of tour of early inflammatory arthritis. And I think to summarize that part of my talk, I just say that initiating treatment is associated with better outcomes of pain and function. We should be referring all patients within 3 days of presentation, and we should be seeing them in secondary care within 6 weeks. As I've gone over, patterns of inflammatory arthritis do differ, and the key is always in a really good story and a close clinical examination. I find particularly that early imaging with ultrasound is really helpful. I want to see all of the palindromic arthritis and the erosive osteoarthritis. And even if I don't start disease modifying medication, I think it's really important for me to be following these patients up. And then finally, if the patients just keep a symptom diary and take lots of pictures, it's always very helpful. So I can either stop there for a second and ask if there's any questions, or I can leave it all till the end, till the Q&A, which I think I probably have to because I can't see the Q&A screen. So I'll move on, and the reason that I've chosen to include seronegative spondyloarthropathies is, number one, because I don't think until I was a rheumatology trainee I ever really understood properly the difference between radiographic AS and non-radiographic AS. And these terms used to get thrown around quite loosely. And then finally it made sense to me. So apologies if it's obvious, and it just wasn't obvious to me, but I just thought I would go over it. Key features in the history and poor prognostic markers. And I've talked in terms of pitfalls about imaging findings and things that can mimic seronegative spondyloarthropathies. And then finally, just a little bit about the treatment algorithms that we have and that we use. So I'm going to give you a couple of sort of seconds to take this slide in. So this slide, again, is from the early inflammatory arthritis audit. And this top graph here is rheumatoid arthritis. The middle graph is mechanical back pain, and this graph is axial spondyloarthritis. And this is looking at symptom duration prior to assessment in rheumatology. And if we take the rheumatoid arthritis part of this out, but actually look at mechanical back pain and axial SPA, people with mechanical back pain in general are being seen between 1 and 3 months of symptom onset. So about 26% of patients or so. Some people obviously are taking much longer to present, between 1 and 5 years. But I think the key thing that I want to draw your attention to is that actually patients with inflammatory axial disease are taking the majority are taking between 1 and 5 years to present to secondary care. And there's a real drive at the moment, which is why I've included this, to try and improve our diagnosis and assessment of people with inflammatory disease. So the most important thing in axial SPA is the inflammatory back pain criteria. And the most important things really are, I think, alternating buttock pain. And often patients will tell you that they are fine when they go to sleep. And then usually about 3 or 4 o'clock in the morning, their back pain or their buttock pain wakes them up. And that's quite a good history, actually, and particularly when it's young men. So what you'll often find is they just anecdotally, they tend to be quite fit. So you'll find a young cyclist who cycles miles and miles, but will clearly say to you, I'm fine, and I wake up and things hurt. Morning stiffness that lasts more than 30 minutes. And usually the pain will get better with exercise. So often people will tell you that they get up, go for a stretch, and things get better. And the other criteria is the age, really. So young age should make you more suspicious of this. And this is my slide. Well, it's not my slide, but it's a slide that I've taken from the Annals of Rheumatic Diseases, in terms of just to highlight the differences between radiographic ankylosing spondylitis, which essentially is when you've got fusion of your sacroiliac joints on your X-ray, which again is a bit late. And so for that reason, the criteria were refined. So you need one of these two. So sacroiliitis on imaging, which is either acute inflammation on an MRI or definite radiographic sacroiliitis on X-ray. And along with the imaging findings, you need one or more of these SPA features. And as you can see, these are quite wide, actually. So, you know, enthesitis, uveitis, psoriasis, and good response to NSAIDs is actually in there as well. Or in the absence of this, you need a positive HLA-B27 blood test and 2 features of SPA. So you need 2 of these rather than just 1. And that tends to give you a sensitivity of 82.9%, and it's 84% specific for inflammatory axial spondyloarthritis. And pitfalls. So, you know, I don't see the majority of mechanical back pain that comes into primary care, and it's difficult. So I think things to always think about: postpartum is a really difficult time to diagnose inflammatory SPA. So there's been a recent study that shows that actually once women have given birth, if you do an MRI, they have changes that are sort of equivocal up to about 3 to 6 months. And so I find this particular subset of patients actually quite difficult to treat. And usually I'm guided more by their history and their inflammatory symptoms. Osteitis condensans ileae is usually when you have, again, women again, and you have inflammation usually on one side of the sacroiliac joints. Other things that can mimic things, so if you've got a transitional vertebra, so you've got fusion of the vertebra at your lumbosacral joints, which is also called Bertolotti syndrome, that will often give you similar pain and changes. And then the other big one is DISH, so diffuse idiopathic skeletal hyperostosis. And we see this typically in men with diabetes. And what you normally get is fusion that's usually unilateral and not bilateral of the spine. And then other mimics just to think about are infection. You can get a gout, sacroiliitis, and then sometimes metabolic changes. So hypo or hyperparathyroidism can result in changes within the MRI. And then in terms of pearls and updated management of axial SPA, so once you're happy that you've made the diagnosis, you do need to try 2 non-steroidals at a maximum tolerated dose, provided there's no contraindications such as a peptic ulcer or asthma. Everybody that is diagnosed with axial SPA should get a Bath ankylosing spondylitis disease activity score, which includes questions like spinal pain, early morning stiffness, and how much pain there is in peripheral joints. And you need to have a BASDAI score of over 4 with a spinal analog score of 6 to be eligible for biologic therapy. So usually our starting point is TNF, and the response criteria are that they have to be on treatment for 12 weeks, and you would expect to see an improvement in the BASDAI score of at least 2. So if that doesn't happen, then there is the option to consider an alternative biological DMARD, which at the moment is IL-17 inhibition or IL-12, IL-23 inhibition. So secukinumab, ixekizumab, and guselkumab, which has just come onto the market. But usually that's limited to psoriatic patients. And then other things that are currently on the horizon. So there's been some phase 3 trials looking at JAK inhibitors, particularly in the management of axial SPA. And these are looking promising and hopefully will be able for us to prescribe soon. So key take-home points, really. So significant delay in the diagnosis of axial SPA. The history is the most important thing. Beware of mimics. So probably usually if it doesn't feel right to you, it isn't right. Exercise, weight management, and smoking are key adjuncts that should be offered to all patients. Treatment algorithms now are pretty good, and most people actually respond very well to non-steroidals and biologic DMARDs. And JAK inhibition is on the horizon. And the other thing I thought I'd mention is there's lots and lots of self-management tools out there for patients who have axial spondyloarthritis. So there's the MySPA app, which is very good. The NAS website is also very good in terms of directing people to self-stretching exercises when you haven't got access to either physiotherapy or hydrotherapy. So I'll move on. And the third thing that I thought I would talk about in my top 5 is gout. And at this point, most people, I don't know, either switch off or roll their eyes, particularly medical students and other junior doctors if I'm ever treating them. But in terms of the bread and butter of what we treat, gout is a significant problem. And what I'd like you to take away from this is actually the size of the problem, the treatment algorithm, and other things that I've chosen to talk about in this are drug toxicity and difficulties when patients have got low eGFRs. And then in Pitfalls, I was just going to go through a couple of slightly odd presentations of gout, which aren't as uncommon as you might think. So why does it matter? So why do we even care about gout? So number one, it's the most common inflammatory arthritis. And depending on which study you look at, affects somewhere between 2 to 5 to 7% of the population. And I think what's really interesting actually is that we think we're pretty good, right? We think we're pretty good at treating gout, and everyone knows that you give a bit of allopurinol, you give a little bit of anti-inflammatory, and there you go. Tell them to stop drinking, stop some shellfish, and people will get better. But surprisingly, hospital admissions for gout are rising. So a local study that was done at King's and at GSTT shows that hospital admissions have risen almost 50 to 60% in the last decade. And that is the equivalent of 350,000 bed days. And it's costing the NHS somewhere between, I mean, it's a big interval, but somewhere between 5.4 million and 35 million per year. And in terms of, impact on the general population, actually, so there's significant morbidity and there's lots and lots of lost working days. The other thing to mention as well is that if you're already in hospital, so if you're already in hospital for congestive cardiac failure or pneumonia, an acute attack of gout will significantly add to your length of stay. And that is a problem because that then increases your chance of getting hospital-acquired infections and overall increasing your morbidity. So this is a reminder slide, really, just to remind you that gout crystals under the microscope are needle-shaped and negatively birefringent. And this is important, particularly actually in secondary care. So the fresher the sample you can get to the lab, the better it is. So often, if you take a sample on a Friday and it doesn't get reported till Monday or Tuesday morning, it's really unreliable and you can't really trust it. The other thing is to look for gouty tophi. So these are quite impressive tophi, and I'm sure most people would recognize this. But if you've got someone that's just got a very subtle starting tophus, it's just important to look. And to look at both the hands and the feet, and to look at the backs of the ears as well. And again, so I've modified this from the BSR guidelines. But look, the key aim in gout is to reduce the frequency of flares to the point where patients don't have any at all. We're aiming for a serum uric acid of less than 300. Interestingly, the guidelines say that ideally patients should be reviewed every 4 weeks. And I think that we know in practice that that is a wonderful ideal, but really, really very difficult to achieve. Maybe easier now with telemedicine and telephone calls, but it's still difficult. And education is the key. So in terms of an acute attack, treat as soon as we can to try and stop any joint damage that might accrue. Non-steroidal, so again, often I get asked which non-steroidal. The honest answer is it doesn't really matter. If you look at studies, there's not very much difference between naproxen or meloxicam. The Americans will use a lot of indomethacin still. So, what I tend to say is if it works and it doesn't cause awful side effects, then that's fine. Colchicine, so usually at a dose of 500 micrograms, between twice a day and 4 times a day. And the rate limiting problem with colchicine, obviously, as we all know, is diarrhea. And then either intramuscular, intra-articular or oral steroids plus adjuncts. And then ideally, you're supposed to see them 4 weeks later for a review of lifestyle factors and cardiovascular risk and medication. I think it's this step that's very, very difficult to get that follow-up appointment in there. Treatment first line usually is allopurinol at a dose of between 50 to 100 milligrams, and we can titrate this up to 900 milligrams if we need to, aiming for a serum uric acid of less than 300. If there's no response to allopurinol, or there's a drug rash, or it's not tolerated, our second line agents are Febuxostat, which again we start at 80 and can up titrate to 120 if needed, followed by other agents usually that we use in secondary care, so benzbromarone or probenecid, and then anakinra is licensed for refractory gout in the inpatient setting. So this all seems really simple, and I don't want to teach anyone to sort of suck eggs, but actually we're not managing gout particularly well. And the things that I find a problem are that it's this step. So patients say to me, "Oh, did I need to take my gout? Was I supposed to be taking the tablets long term?" And often they'll come and see you 3 months later, having run out of tablets and not bothered to take them at all. So I will move on. So my pearls for gout treatment. The problem is not straightforward gout. The problem is when they've got an eGFR that's like 30 or 25, and what you do then. So I've used this table, and it's from the American Kidney Journal, just to highlight really that actually we're a bit stuck. So if you've got an eGFR of less than 30, usually what I will do is start allopurinol 50 milligrams, sort of alternate days, check it's tolerated, and increase it as much as I can. For Febuxostat, they say start at 40, maximum of 80. And again, mostly well tolerated, and so it's just a lack of trials really that we don't have the data for. We get stuck with uricosuric agents because most of them are contraindicated, and pegloticase we use very little of, mainly because it can cause quite a big immune reaction. So I'm going to leave this slide up there just for a second, but obviously if you've got the recording afterwards, it's just quite a handy slide. And really, sometimes you just get stuck and you've got to give patients steroids. There's no other way around it. Or you've got to wait for them to start dialysis. The other thing that I always get asked about is Febuxostat and cardiovascular toxicity. And in fact, actually, I had a patient last week who said to me, I'm going to have an arrhythmia and die, so no thank you, I would rather not take this drug. And where this data came from was this New England Journal of Medicine paper where they looked at about 6,000 patients that were randomized to allopurinol or Febuxostat. And they looked at major cardiovascular events and cardiovascular deaths. And when you analyze the data, so there was a slightly higher hazard ratio of cardiovascular events in the Febuxostat group, and a slightly higher mortality due to cardiovascular disease in the Febuxostat group. There was a further meta-analysis that followed on from this that showed a slight increase in mortality. So the MHRA current guidelines are avoid treatment in Febuxostat in patients with pre-existing major cardiovascular disease, unless there's no other treatment option that's available. Now, again, on the face of it, that's a very nice, very easy statement, but I think we all know that what do you class as pre-existing major cardiovascular disease? So what I tend to say is, if they've had stents, if they've had a recent heart attack, if we know that their ejection fraction is particularly low, then I will try and avoid it if I can. But yeah, and of course the other problem is the people with the cardiovascular disease are also the people that have the low eGFRs. So treating this population of patients is difficult. And then in terms of varying presentations, I mean, this is just really to remember that often olecranon bursitis can be gout, and gouty tenosynovitis, if you can't get someone that's got swelling and pain of the whole finger, that can often be gout crystals as well. And the other thing not to forget is you can actually get spinal and sacroiliac gout. And if you look in the case reports, really, you can find it anywhere. So yesterday I found a case report where it was in someone's eye, which I actually haven't ever seen before. And so this is just to show you, so this is a picture of a tophus in a sacroiliac joint. And recently I had a similar patient, and they do sometimes actually present with really high inflammatory markers. So this patient in particular presented with a CRP of I think almost 100. And so you've got to do the normal things that you will normally do. So rule out infection first, and then treat as things start to come back negative. This again is another picture of an erosive facet joint arthropathy that's associated with gout. So just to summarize, I suppose then my top tip number 3 is that gout's common and it's treatable. We're aiming to titrate the serum uric acid to less than 300. Tophi can take a long time to resolve. So a lot of the time when you've got somebody with acute tophaceous gout, you've just got to get them to be patient. So tophi can take somewhere between 6 months to years to fully resolve. And in some patients, they don't ever go away. And sometimes surgically laying them open is the only option. But the risk with that is infection. And then gout and CKD and heart failure is always a nightmare, and it's difficult for both primary care and secondary care. I suppose the key things I would say is not to be afraid of giving low dose allopurinol, so starting at maybe 50 alternate days. And sometimes you've just got no choice and you've got to give steroids or wait for dialysis. So I hope I've made gout as non-boring as I possibly can make it. And then I've just got 2 more sort of key things that I think are important to go through. And then I'll take your questions. So GCA, and I'm sure all of you have been to lots of talks about GCA, but what I'm just going to go over is the epidemiology, recognizing it, and then imaging pearls and pitfalls. And pitfalls is the main thing here, because there's lots of things that mimic GCA that aren't. So it's by far the most common vasculitis. And the key thing to remember is it affects the elderly. So the mean age of presentation is about 76. Affects women more than men, and actually is quite rare in the non-Caucasian population. So having worked in East London and South London for a long time, I rarely, not impossibly, but I do rarely see Asian or Afro-Caribbean or Black patients that have GCA. In the white population, the incidence is about 20 per 100,000 if you've got a population of over 50. And again, the other question that I often get asked is, well, you know, how do you tell the difference between large vessel vasculitis that affects the aorta and the subclavian arteries, or just cranial GCA? And this table is just helpful. But look, the key features really are the headache, the temporal artery tenderness. Jaw claudication is a really specific sign. And the question that you really want to ask them is like you would ask somebody for peripheral claudication, really. So does the pain come on after they've been eating? So once they've been using their artery for a while whilst they're chewing, is that when the pain comes on? And that's kind of true jaw claudication. Fever, weight loss, systemic symptoms, often in the elderly, will be the first thing that present rather than the actual headache. And sometimes when you go back, they've had polymyalgic symptoms for years. So they've got pain in their shoulder girdle and hips. And so for purposes of classification, you need at least 3 out of 5 of these. So over 50. So if they're under 50, it's really unlikely to be giant cell arteritis, and we need to be looking for different causes. A new onset of headache, thickening or pain of the temporal artery, and an elevated ESR. And again, this is difficult. So my cutoff for ESR tends to be your age plus 10 divided by 2. And that's a really old school way that I got taught many years ago. So an ESR of 20 or 30 in a 80-year-old, I usually won't get too worried about, but you know, it's a spectrum, I suppose, is what I'd say. And then the gold standard is a temporal artery biopsy. And so you get a piece of the tissue showing a vasculitis, usually has got some giant foam cells in it with multinuclei. Now, the problem, though, is getting a temporal artery biopsy, particularly in the pandemic, has been almost impossible. So we are more and more and more relying on temporal artery ultrasound. And the thing that it will show you is thickening around the temporal artery. So you have a halo sign, which is what this is. So you've got thickening around it in cross section, and you can see the thickening of the artery here. So there's a normal one with normal good wall linings, and then as the disease progresses, this gets thicker. And these are just some more images of blood flow on ultrasound through the temporal artery. The other thing that's slightly more helpful, and we're doing more of, I suppose, are PET CTs. And PET CTs I tend to do when people don't respond the way that I want them to respond. So if you started steroids and their inflammatory markers are still raised, they're getting recurrent relapses of disease, usually at that point I will do a PET, and that's to look for 2 things. So number 1 is large vessel vasculitis. So is there involvement of the aorta and the larger vessels? And number 2, actually, if it's not acting the way that you think it is, then go back and revisit the diagnosis. So have we missed lymphoma? Have we missed malignancy? And those are the 2 things that I will always do. Again, these are just some more images of thickening. And as you can see, so around the wall of the aorta, there's a lot of thickening here. And the risk of this is going to progress to dissection or rupture. Now, this slide really, so for the pitfalls, it's just remembering what else GCA can mimic. So at absolute minimum for every single patient, I get a chest x-ray. And the reason for that, number 1, is if we're going to be starting immunosuppression, we want to know that there's nothing on the chest x-ray to start off with. But number 2 is that actually I've seen lung cancer mimic this. And the other things to remember are atherosclerotic disease is the common one. Infection can sometimes do it, so making sure there's no endocarditis. And then there's the slightly more odd ones, which again, it's up to us in secondary care to rule out really and to think about what we're doing. Important things that are slightly more common, so if the CRP and ESR are really not that impressive, then things to think about, so herpes zoster, migraine and other causes of headaches, whether or not there's anything infiltrative. So I have seen a pepper pot skull from myeloma that's presented as GCA. So as part of my workup, actually, most patients with an ESR that are that age will always get protein electrophoresis and immunoglobulins as well. Cervical spine disease is quite common. So if you've got degenerate disease at C1, C2, you will often get headaches that move upwards. And then the other things to think about are ENT pathology. So is there any sinus disease or temporomandibular disease that's causing this? What I tend to say in terms of management, look, if you're in doubt and you really think it is, just start steroids. The likelihood of you doing harm, unless it's a fulminant infection, is very low. Things we should be routinely doing is checking peripheral pulses, blood pressure in both arms, listening for any bruits or aortic regurgitation, and a baseline chest X-ray. And then just not to forget supportive treatments. So often if there's been ocular involvement, we will put in aspirin, a PPI for gastroesophageal reflux, and then adding in calcium and vitamin D. And usually these people are also high risk for osteoporosis, and it's always forgetting not to co-prescribe treatment for this. And the most other important thing is to consider comorbidities, really. So the problem is diabetes and cardiovascular disease and glaucoma, and particularly where I work in South London and East London, the risk of developing steroid-induced diabetes is great. So I've touched on steroids and what we do, and then the next question is, what do you do with refractory GCA? So my rule of thumb tends to be, and this is not evidence-based, this is just what I do, is I will try and reduce the steroids at least twice. And if the patient still has raised inflammatory markers, at that point, you need to sit down and think about what we can use instead. So in terms of disease-modifying therapy, methotrexate or leflunomide, and then the thing we use more now is IL-6 inhibition with tocilizumab. So NHS England has commissioned tocilizumab for use in 1 year, up to 1 year, in patients with giant cell arthritis. And actually it works very well in terms of getting rid of inflammation quite effectively. So just to summarize, and then that leaves me 8 minutes to talk about COVID. GCA is an uncommon but serious cause of headache, quite rare in the non-Caucasian population. Make sure that we've always thought about the differentials, infection, malignancy. If you really think it is, start steroids and refer in, and you won't have done any harm. Referral to ophthalmology if you think there's any eye involvement. And then just remembering that steroids, as great as they are pretty awful drugs to be on long term. And we really need to try and get rid of them as soon as we can. So whether that's by adding in a DMARD or tocilizumab, that's sort of where we are. And then finally, in my last 7 minutes that I've got left, so I thought about what I should put in for this fifth, what I think everyone should know. And I thought fibromyalgia obviously presents much more than COVID, but that's a whole separate talk. So what I thought I'd do is actually just talk through, not extensively, but stuff that's been happening during COVID-19 in rheumatology clinics. So important things to say, that myalgia and arthralgia are presenting features of COVID. And during the pandemic, we have noted varying degrees of CK. And usually that isn't an inflammatory myositis. It's usually a little bit of rhabdomyolysis associated with being acutely ill. Or it can sometimes go up as part of the systemic inflammatory response that we've been seeing in COVID that we've had to treat in ITU with tocilizumab. Systemic inflammatory syndrome, or the Kawasaki presentation, is important, I think, particularly in primary care for children. So we've seen young adults present almost with a large vessel vasculitis picture after getting COVID. So they get inflammation of the large vessels, persistent temperatures, high fevers, and odd rashes, odd vasculitic rashes. And usually these patients are pretty sick, and I end up seeing them in ITU. The other thing is I've seen a lot of is a post-COVID-19 reactive arthritis. Anecdotally now, most patients settle after just one course of steroids or an iron depomedrine injection. But what I say is, look, we investigate them as we would any other inflammatory arthritis, and treatment still consists of steroids, disease-modifying agents. But most people so far, so I'm coming up to about a year of maybe seeing my first post-COVID-19 reactive arthritis. Most patients are settling without needing long-term disease-modifying drugs. And then the hot topic on everyone's lips, which again is another talk in itself, is long COVID. So as part of my role, I've been sitting on long COVID MDMs. And really what we're seeing, so if you look at the last report, it's interesting. So women are getting long COVID much more than men. And interestingly, actually, it tends, at the moment, it looks like Caucasian people are getting long COVID much more than Black and Asian and ethnic minorities. I think as data comes out, maybe that will we'll have a bit more of an idea as to why that is. But if I just give you an idea of what's happening on long COVID MDTs at the moment, it consists of, so myself and another rheumatologist, neuropsychiatry, and they're actually probably the most important people in terms of functional symptoms and functional planning. And respiratory physiotherapy are the other ones. So we know that people that were hospitalized with COVID have got dysfunctional breathing, and often long-term physiotherapy to try and correct that really helps. We're trying to steer away from prescribing pregabalin or gabapentin, particularly in the context of the new chronic pain guidelines. But sometimes getting the pain team involved is also important. And to be honest, the main rate limiting factor in all of this is access to services. So we can make a plan and we can say what you need is a course of physio and hydrotherapy and a bit of cognitive behavioral therapy. The problem is executing that plan. And in the last slide, the other thing that I expect many of you might have seen actually during the pandemic is this sort of really strange perniosis presentation. Now, I have seen a lot of this in the last year. And what I found really interesting is it seems to be a particular age range, so between 20 and 40. And this picture here is typical of what we've been seeing. So you get basically swelling over the PIP joints or the MTP joints associated with what looks essentially like a chilblain lupus. And these are people who have never had Raynaud's before, they've never had chilblains, and all of a sudden in the last year, they've presented with this presentation. And they get pain, burning, and itchiness, and a lot of the time the skin over the PIP joints will break down. So different people are calling it different things. The dermatologists are calling it COVID hands and feet. What I found really interesting is a lot of the patients that I've seen haven't actually had COVID, and I've had the liberty of testing their COVID antibodies and they've come back negative. So I find it really difficult to purely just call it COVID hands and feet. So what I say to them is, look, I've seen loads of this during the pandemic. I don't actually know whether it's definitely COVID related or not. The other things that we've been doing in the pandemic is we've all been at home. We've been washing our hands a lot. We've been using lots of chemicals. Some people come and tell me that they've never had cold showers in their life before, and now they're having cold showers, and this has happened. So the honest answer is I call it COVID hands and feet, but we don't know. Treatment usually is really responsive to steroids. So either one intramuscular depomedrine injection and then topical corticosteroids for the skin tend to work very well. Again, I'm coming up to about 6 to 8 months of having followed up the first lot of patients that I've seen. And most of them are getting better, but it is summer. So I'll have probably a bit more idea by December whether or not this is a phenomenon that's going to carry on going or whether it was just isolated and has got better. The other things to mention are I've seen a lot of vasculitic rashes post-COVID. And what I would say is if it looks like a vasculitic rash, absolutely refer it in. We will see it. I've got one patient who has got PR3 antibodies following we don't know if they were already there, but following the vaccine. And so what I say is, if in doubt, just refer in. And then this just shows you the other end of the spectrum where actually things are so extensive that you almost get purpuric rash with breaking down of the skin. And usually these patients are really quite unwell and in ITU. The other thing I should say with this slide is I've said that this is associated with COVID, but actually I've seen this also post-injection. So some people have come back after the vaccination. And then finally, just some vaccine questions and answers that people ask. So what do I get asked? Can I have my vaccine if I'm on immunosuppression, or I've got lupus, or if I've got rheumatoid arthritis? My answer to that is yes. So the thing that is associated with bad outcomes is active disease. So if you take out cyclophosphamide and rituximab, for which there is data that perhaps these patients do slightly worse if they get COVID, the risk of getting COVID is higher than the risk of disease flare. And if there is disease flare, we can always treat that quite effectively. Treating COVID is a bit more hit and miss, is what I tend to tell people. The second question that I get asked a lot is, I'm having a flare-up of my disease, should I delay the vaccine? And usually my answer to this is, if we are giving you corticosteroids acutely to treat the disease flare, then probably yes. Maybe delay it by a week or two until the steroids are finished. particularly with, I think, lupus. The third thing I get asked a lot is the vaccine going to cause my disease to flare? And my answer to that is, in the majority of patients that I have seen, no. In the last year, I've probably seen about 10 to 15 patients who've had a flare following their vaccine. A lot of the time they didn't have well-controlled disease in the first place, so it's difficult to know which is which. So my tagline for that is, yes, it could, but again, the risk of not having the vaccine is higher than the risk of your disease flaring. And then the other questions are, should I stop my DMARDs before the vaccine? There's a little bit of evidence coming out now, but it's not fully kind of validated yet, that perhaps being on methotrexate does reduce your antibody response to the vaccine, but we do not routinely stop. Patients will delay their own doses, and that's fine, and that's their choice. But I wouldn't routinely stop any disease-modifying drugs prior to having the vaccine. The only caveat to that is what I said about rituximab, and usually in secondary care, we will delay the infusion until the vaccine has happened. And then finally, does it matter what vaccine I have? So particularly in the light of the clots and the AstraZeneca, again, so we are a bit cautious. So patients with lupus who have lots and lots of antibodies, who are known to have antiphospholipid syndrome, usually our preference is for them to not have AstraZeneca. And that seems to have filtered its way through hematology and rheumatology, and we tend to get our patients vaccinated on site. So that was a lot, and I've done a lot in an hour, and maybe if I had to do this again, I would pick slightly fewer topics. But just to summarize, we've seen lots of COVID-related complications. So far, it seems to be a one-off hit and things are getting better, but I'll know a bit more this winter. We have got long COVID clinics across the country, particularly in London, and referrals are either straight from GPs, or we have an MDT where secondary care physicians, so neurology, respiratory, can all refer in. And flares and vasculitic rashes have been seen both post-infection and post-vaccine, so please refer them all in. And finally, that active disease is worse in terms of COVID outcomes than the immunosuppression. So just finally, I hope that was enjoyable and you found it interesting, and I hope my pearls are of some use. The main thing really is, at the moment, our patients are worried. So they haven't seen their rheumatologists for a long time. They haven't seen their GPs for a long time. And I think the key thing as well in all of this is just trying to focus the consultation to their needs, which often is not their rheumatology problem. It is many other things. And that's why I put this little picture in at the end. So, my arms ache to hold you, or maybe it's just my arthritis acting up. And sometimes it is really difficult to tell the difference. So with that, I will take any questions or comments, and I can, oh, hang on, how do I see this? Right. So I've got one question to say, if patients have been on diuretics for heart failure and gout, how is this managed? So again, there's not an easy answer for this. Usually, if it's just a knee swelling or an isolated joint, then an intra-articular injection is by far the best way to manage it, because they need their diuretics for their heart failure. They also inevitably are going to have a low eGFR if they are on that amount of diuretic. And usually what I will do is I will start allopurinol 50 milligrams daily or alternate days, try and up titrate it. The other problem obviously with giving systemic steroids is it's going to make the fluid retention worse. So usually you end up either doing an intra-articular injection, giving the lowest dose of steroid possible, and then potentially starting allopurinol. And then the next question, I hope that answers the question. The next question is starting allopurinol after one attack of gout. So the guidelines will say usually 2 attacks or more. What I would say though is that if there are erosions on the foot x-ray, I will just start it. And the other thing I will say is if there is grumbling pain, so often what you'll have is patients have foot pain that comes and goes, and then they have an acute podagra attack. And that would be the only other case. And if their uric acid is well over 500, 600, I may start it on first presentation. And then the last question is, why is palindromic rheumatism called palindromic rheumatism? So it is basically because it comes and goes. in terms of it being a palindrome, so usually these patients are perfectly well between attacks, and will, really you wouldn't know they had rheumatoid. As to why they decided to call it that, just as opposed to relapsing and remitting, I don't actually know the answer to. But I hope that was helpful.